exhibit hall. For our next session, we're going to be talking about dry eye advancements. I would like to introduce myself. My name is Jaclyn Garlich. I'm going to be moderating the panel of amazing doctors that we have talking about this therapy today. I'd like to bring them on now. We've got Dr. Epstein, Dr. Lazar, Dr. Wolfe, and Dr. Nelson. We are going to be talking a little bit about OptiLight. We've all implemented OptiLight technology in our practice, and we're going to talk a little bit about the rationale behind implementation, how we implemented, the financial results of that, and the clinical results of that. So welcome, everyone. Thank you for being here.
Thanks. Pleasure.
Thank you.
Hi.
Why don't we start by having everyone introduce themselves? Dr. Lazar, why don't you start?
Sure. My name is Dr. Lazar. I practice in Greenwich, Connecticut. I implemented doing light-based therapy in my practice over a year ago, and I've had a tremendous success.
Wonderful. How about Art?
Hi, I'm Dr. Art Epstein. I practice in Phoenix, Arizona. A lovely day in Phoenix. My practice is limited to dry eye, and actually I've been using OptiLight and luminous technology for probably about 3.5, 4 years.
Wonderful. Dr. Nelson?
Dave Nelson from Madison, Wisconsin, and I've practiced here for over 30 years. From Nebraska originally, got my optometry degree at Indiana and my MBA at UW-Madison. Became board certified in 2014 by the American Board of Optometry. We've been using OptiLight for 4 years now, and it's just amazing. And so I'm real excited about being able to talk about this. When I was involved in the Wisconsin Association and the AOA, we were able to get the ability for optometrists to prescribe medications over those 20 years or so. And now all states can do that. But the frustrating thing for me in treating disease is it doesn't get to the underlying cause. And so I'm really excited to talk about getting to the underlying cause today with the luminous technology and dry eye disease and meibomian gland dysfunction.
Great. All right. Save the best for last. Chris.
I'm Chris Wolfe. I practice in Omaha, Nebraska, and I'm in a primary care practice, and we do a lot of anterior segment disease and a lot of ocular surface disease in primary care practice. I believe it really is hard to overlook once you start looking at it. And we've incorporated a lot of technologies in our practice to manage those patients. We've had light-based technology and OptiLight specifically for the last about 7 months in our practice. And it's been great for our patients. It's been another way to meet them where they're at. So I'm excited to talk about this.
Yeah, this is great. I'd like to hear from all of the panelists on this question here, but what made you implement OptiLight light-based therapy into your practice? Let's start with Dr. Wolfe.
Well, really, it was the need for something additional for patients where they either needed some sort of meibomian gland treatment that we weren't able to provide with other mechanisms. And so what I find in patients is that when we think about how we're going to treat them, there is this ultimate thing that we need to be able to focus on, which is patient preferences. And some patients have preference for medications, and many patients have preference away from medications. And if all we were utilizing was medications or other procedures that didn't address that underlying problem, then we weren't meeting them where they were at if they had a preference for something that wasn't going to be related to something they have to do every single day, multiple times a day. This really allowed us to address those things for patients in a way that kind of meets their preferences.
Yeah, that's great. Let's hear from Dave. What about you?
Well, I was, again, frustrated with multiple therapies and pharmaceutical examples. And when I saw the TFOS-DO study that came out in 2017, the second workshop, defining meibomian gland disease as the biggest problem, I thought, yeah, that makes a lot of sense. And in that report, it showed that 80% reduction in dry eye symptoms with using the IPL technology. So I thought, wow, that's something that I really can hang my hat on. And they've been talking a lot about dry eye therapy and trying to make it simple. There isn't anything more. It works on heat, it kills Demodex on contact, it gets rid of telangiectasias, and then it works in a way that's really interesting, photobiomodulation, which Dr. Jacoma talked a little bit about. But it increases cytochrome C oxidase, which increases ATP, makes the glands work harder and the mitochondria are the target issues. So it makes the glands work better. That's awesome.
And Art, can you talk about your thought process on this?
Yeah, it's interesting. With a practice limited only to dry eye, I found myself always looking for the next magic bullet. Of course, there is no magic bullet, but there are a lot of very, very effective bullets. So I approached light-based therapy with typical New York cynicism. I'm a New Yorker; you can't quite take that out of the person. At first I looked at some of the data. It was interesting. It was actually Laura Perriman that really kind of pushed me over the edge. She's very scientific. I think, I approach things in a very structured scientific manner. And I began to look at needs in our practice. We were doing well with the technology we had, and we're a very tech-oriented practice. I literally have every type of expression technology. And yet we had a lot of patients that had rosacea facies, ocular rosacea, and weren't doing quite as well. I tend to be very structured in my approach. So, I don't jump to medications initially. I use other approaches that, kind of build, into hopefully a successful outcome. And I finally decided to make the leap, thinking that it was going to be very, very limited just for a small subset of patients. As I began to use it took a while because I was traveling and doing a lot of speaking at the time we originally brought the technology in. My wife started yelling at me that this was not going to be another, and we were not hanging clothes on it. I finally began to implement it, and it was almost just an explosive experience. I think I'll talk a little bit later about how we actually implemented it in the practice, but it went from limited use to incredibly active use for the vast majority of patients in our practice, with amazing success, mounting success, which of course builds on additional use and reassurance that something is making a real difference. So it literally is now a major foundation of our practice.
Art, you talked about Dr. Perriman having a role in your acquisition of getting light-based therapy in your practice. And I don't know if you know this, but you were one of the people that also got me into getting the OptiLight. You and Ina, both of you, were like, oh my gosh, you have to get this. And so you had a little role in that for me there.
Yeah, that's great to hear. That's great to hear.
Ina, do you have a few comments here?
No, I absolutely share all the comments that were said previously. When I opened my practice, I specifically opened it with purpose to have it as a dry eye practice. And we started as a drop therapy, and of course you want to offer always more to your patients. And what I found that when those patients were on drop therapies for about two to 3 years, they start to plateau. And that's when I realized I need to do better for my patients. And that's when I, brought in the IPL and started implementing it, which has been incredible, because there are patients, just like Dr. Wolfe said, there are patients that are looking for dropless therapy that will still be very, very effective, if not more effective. So I definitely share all the thoughts.
Yeah, I agree with you. I certainly have patients that don't want to go any medication route. And, perhaps it's the people that I'm speaking with that have OptiLight, but I've yet to meet anyone that really regrets actually purchasing that device. Everyone just has glowing reviews of it. Dr. Epstein, can you talk a little bit about your first impressions, just from the perspective of actually using the device?
Yeah, thanks, Jackie. It's funny. I guess you could classify me as a geek. My original path was engineering, and I love things well built. Literally the first impression I had is this thing is built to NASA grade standards. I mean, this is incredibly well engineered. It's a beautiful, beautiful piece of equipment. I jokingly call it to patients R2D2 sometimes. They get a laugh out of that because I want to make it kind of accessible to them. But in terms of just construction and build and reliability, it's extremely impressive. It gives confidence, and it also gives you a sense of power, because this is one of the few things we have that can directly affect change. I often tell patients that I literally hold power of changing their state in my hands, and that's been very much the case. I believe we're going to have an opportunity to talk about some of our most impressive cases, the most meaningful cases to us, and in one case in particular, I literally have changed someone's life, and I can directly attribute it to light-based therapy.
Yeah, that's incredible. Dr. Wolfe, can you talk a little bit about how you incorporate this into your treatment plan for a patient?
Yeah, so when I historically kind of approach patients with ocular surface disease, my focus has always been on the meibomian glands. And so I always tell the story when I was in school. So this is 14 years ago, that a buddy of mine and I squeezed meibomian glands with a scleral depressor because we read about it, probably an article that Art wrote. Now he doesn't like to do that. It's below him. But we were fascinated because it was a patient that had what we would consider non-obvious meibomian gland dysfunction, telangiectatic vessels, no anterior posterior blepharitis signs like we were trained at the time in school. And it literally changed my approach to taking care of patients in our practice. So I almost always now can't get away from pressing on oil glands, whether that's digital pressure or blink pressure or mastrotopaddle pressure. And so our approach, similar to Dr. Epstein's, was always to say, let's do things we can do to try to improve those glands first. But in cases where you need some additional anti-inflammatory benefit, you can't get that with the historical tools that we've had in terms of procedure-based therapy. And so we kind of had exhausted all of our options for in-office procedures to treat inflammation and to treat the meibomian glands. We had already had expression devices in addition to our hands and other manual tools and in our practice. And so it was just sort of this step of, we need to fill a need of patients. And one of the things I think is really important is when you're thinking about taking additional steps, is in your clinical record to kind of make observations that are related to potential additional steps. So one of my point in saying that is that we can make observations about inflammation with staining, with other testing, in-office point of care testing. But we can also make observations along the eyelid. So what I started doing when I was considering is probably about a year and a half, where we were considering bringing on light-based therapy in our practice, where I was making notes specifically of the level of telangiectatic vessels that I was noting on the eyelid margin. So grade 1 through grade 4. And that was just my general sense of how much telangiectatic vessels there were, or how many. And the important part to me was, once I kind of reflected back on that over the course of time, didn't have to be a few months, but in my case, it was over a year, I started noticing that every single patient would have that observation. It would come out of my mouth. My scribe would include it in the chart. And so it made it, I think the point is that knowing that that's one of the primary mechanisms for light-based therapy to have an effect on patients, I could look at my chart and know that, or I could look at my charts and know, man, I've got a ton of patients in my practice that have this problem that we can help them solve. And so that's one of the ways that allowed me to be confident in incorporating this into our practice and knowing right away which patients it's going to have some benefit on. And then from there, you obviously find other niches, but that's how, in my mind, I justified knowing that this was going to be a technology that was going to work for our patients.
Like, Chris, I could not agree with you more. I do that same sort of thing when I'm thinking about implementing a new technology in the practice. I think, okay, well, how often do I actually see these patients that have this problem? And once you really start examining that eyelid margin, you see vascularization on that eyelid margin on so many patients. And that's where something like light-based therapy is so effective at treating that inflammation within the actual eyelid. Dr. Lazar, can you comment a little bit on how you implement or how this fits into your dry eye protocol?
No, absolutely. When you market yourself and your practice as a dry eye specialty, you're going to get patients that have already been treated somewhere else, and they come to see you as a second opinion or a third opinion. And what I've noticed, they're all being treated the same way. We have the therapeutics, they do the warm compresses, lid scrubs. And how I started thinking like, okay, well, I am their second opinion, but I really don't have anything else to offer besides what they already did. And I started, of course, you look at the lid margin and at the meibomian glands. And what I found very helpful is I added the anterior segment camera, and I also have a topography where I can take a video of their tear film, where I can show it to a patient, and that's been very helpful to analyze and see how else I can help these patients. So with the lid margin and vascularization and meibomian gland loss, we see really from children to adults due to the screen use. I think that by using the IPL and adding the light therapy has been really life-changing for these patients, because now I can say, okay, this is what you've done, but this is what we can do. And that's how we can improve long-term effects of the dry eye you currently have. We all know that meibomian gland disease is really the 85% of dry eye disease. So that's how it's, I try to approach it with my patients, to really educating and showing them, and then really hearing back their feedback and what they want to achieve.
Yeah, all good points. OptiLight, IPL is an out-of-pocket cost for patients, and I'm curious how you handle that, or if there was any concern about incorporating this sort of cash-based procedure to your patients. Dave, can you talk a little bit about that?
We have people coming from Rockford, Dubuque, outlying areas. It's surprising. They find us, and they're not cost sensitive. They're looking for a solution, and this IPL therapy provides that solution. The device. It starts at 400 nanometers and it delivers light up to 1200 nanometers. And what we use is a cutoff filter at 590 with a triple pass that Dr. Toyos developed from Tennessee. And what it does is it cuts off everything below 590 and it gets all the way up to 1200, which is infrared light. This is intense red light therapy, and it actually makes an enormous difference. Patients feel it after the second treatment, not always the first, but the second treatment for sure. And then the third and fourth, when we implement those, they're believers, and now they're singing praises, and they're telling other patients. So I think that it's one of the best things that I've put in my practice in 20 years for patient care, for patient acceptance, and as well for the practice. The practice is very profitable because of us being able to do this.
Yeah, I couldn't agree more. Go ahead.
Sorry, I was going to jump in and add something, yeah. Jackie and David. I think one of the things when I think about incorporating new technologies into our practice, specifically that are out of pocket, for some reason, the barrier usually I don't find to be the patients, it's the optometrists. So for some reason, optometrists are totally fine selling a premium pair to the patients in their optical, but a service that isn't covered or and that they perceive as being too expensive, they're really apprehensive about offering it. And I find like if you can shift your mindset in terms of saying, look, this is a value. This is a value, just like a premium pair of eyeglasses or a premium multifocal daily lens. This is a value to you because I know that X, Y, and Z, all the things that David laid out, they're going to work. It's going to be effective, and it's going to allow us to treat those dry eye signs. And so if you have that kind of confidence and not worried about what the patient is going to say if they don't want to pay for it or they do want to pay for it, once you get beyond that, then it becomes an easy proposition. You don't have to convince yourself that it's the right thing to do. You're just telling the patient that it is the right thing to do. And the patient will believe because you believe. And I think that's such a huge thing for us to consider, is that we're usually the barrier on price, not the patients.
What really well said, Chris. I mean, you literally hit the nail on the head. A couple of years ago, I wrote an editorial called "Optometric Guilt," and I likened it to other forms of religious guilt, where we just can't make that leap of looking the patient in the eye and saying, hey, this is something that really is going to make a difference in your life. A lot of it has to do with your own belief in your ability to provide care. If we feel guilty about it, patients pick that up, and it becomes very, very difficult to convince them. And the reality is, in my experience, I find light-based therapy, IPL, to be the easiest to present to a patient of all the things that we do. I think some of it is because they're familiar with it. I think it's gotten popularized by photofacials and rosacea treatment, so they're familiar with the technology at some level. So explaining how it works for them and believing in it really makes a difference. But I wish if we recorded what you said, I want that clip because you hit it right on the head.
I would.
Oh, go ahead, Ina.
I just really want to, I add to this great conversation because I have my colleagues call me and message me all the time. Are a patient being resistant to the cost, or how are you telling this to the patient? What I say is, these patients, they come to you as an eye care professional. They want your honest opinion. They want you to be able to offer to them the best we can. We're not there to be their financial advisor. So if the patient has a need and this is the way to treat them, as a eye care provider, as someone they're looking up to, we have to let them know, and we have to tell them, listen, I understand this costs money, but this is really what is going to address the dry eye and meibomian gland dysfunction, meibomian gland loss that you currently have. And it's just, I think it's this is why we're here, to treat our patients, not to advise them on finances.
Yeah, you guys all, as Art said, you hit the nail on the head. I think there's a lot of psychology, which I don't totally understand, behind the prescribing doctor. And I kind of think about it like, if this is my patient here, what is the absolute best thing for them? And I'm going to let them decide whether the price is right or not right. And the other sort of thing that I found is that patients are someone who I think would not consider this therapy at all, thinking that it's too expensive. I had this woman who was in monthly lenses. They were uncomfortable. She told me she overwears them to save money. She ended up going, she was like, oh, IPL, I definitely want to do it. So someone who I mentally would think like, this person's never going to go for this out-of-pocket cost, totally did it. So that's a good example, is like, you don't judge what the patient's wallet is. Let them decide if they want the therapy or if they don't want it.
Two things that I would like to add to this is, make sure you do your staff. If the staff is being treated, they can relate the information that they're receiving based on their dry eye going away, because our staff has it too. The second thing is, talk to your aesthetics practitioners in town, because they're doing IPL. They don't get around the eye. They don't want to mess around with that. So they'll send you patients. I had my first referral from a cornea specialist at UW for IPL. I think that's the first time I've ever gotten from a tertiary specialist. But he couldn't get the IPL, so he said, hey, you got it. Yeah, you go for it. So he sent them to me.
That's wonderful. Yeah. All right, let's talk a little bit about the procedure itself and how you introduced OptiLight to your patients. Ina, why don't you start with this?
How do I introduce it? Well, of course, we do a very thorough exam, medical history. We take pictures. We look at everything. And of course, from my own experience, it is much easier to treat a patient that has symptoms of dry eye, some meibomian gland dysfunction, but they still have oil glands. They still have these meibomian glands that are there. Those patients are going to have, they will report they're feeling better after the first treatment. Those patients that have, moderate to severe meibomian gland loss, those are going to take much longer to treat. So it's important to let the patient know you need it. We do need to treat you, but it might take longer until you get and will say, oh yeah, my eyes are feeling better. So I think patient education, patient expectations is extremely important. But after that, it's just once they do it, once they experience the first treatment, once we do the whole, I spend about 30 to 40 minutes with a patient. I do all the treatments myself. Patients are very, very happy. And even after the follow-ups, after the 4 treatments are completed, they come back and they do ask for retreatment or the touch-ups.
Art, can you comment a little bit about this also?
I can actually. For me, again, everything is stepwise. We spend probably about 45, 50 minutes with a new dry eye patient. For patients who I identify as being appropriate candidates for IPL, I'll bring up the technology, discuss the reasons why I think it would be appropriate for them, and depending on where they fit in the overall scheme of things. In other words, if I think they're going to need IPL sooner rather than later, I explain what it does, explain what my expectations are, even explain a little bit of how it works, the physics of it, so they're educated. And this is kind of part and parcel of how I approach things. So, I consider a good deal of that time spent educational, empowering them by educating them. And then I will do one or two things, actually one or three things. I will postpone the IPL until after the initial therapy has, gone through its intended course, could be, 6 weeks, 8 weeks, something of that sort, for patients who I think are going to benefit and need it sooner than later. I'll explain that and, suggest that it would be helpful if we schedule it as part of the initial therapy. And for those that are really severe, I tell them that there's almost, it's almost certain that they're going to need IPL, and the sooner we do it, the better. And always give them a choice. I don't want to try to impose my thinking on a patient without engaging them in the thought process. And it works really, really well. I explain costs as well, which I typically don't do in a lot of other things. I usually have someone who comes in and does that, and explain, the procedure timing and so forth. So, for me, it's very much a part of my every interaction with almost every single patient.
Dr. Wolfe, Dr. Nelson, do you want to comment on this?
David, were you going to go?
I can. It's up to you. So
yeah, go ahead.
So we have e-blast that we sent out. It's on our website. We have it in the room. R2D2 sits in the room. As opposed to Dr. Bremer, occasionally I'll see somebody that gives me such signals that I just go ahead and fire up an IPL and do it right there in the exam. I do like bringing people back for dry eye workups. We have a myographer, and that's very helpful. We have Tear Lab. We use that. But again, I started using a dry eye workshop day that was going to be Tuesdays and Thursdays, and that just went by the wayside because this thing is so fast to fire up and do a case that you don't really need to limit yourself and try and box people into a certain time of day when you want to call something a dry eye workup. But I do like bringing people back, like Dr. Bremer said, but I don't always do that. Sometimes I start them right away.
Yeah, I would agree. I think, from a primary care standpoint, the way we first started integrating this was that we would, on Monday morning, for example, I didn't want this to interfere with my normal clinic day. So on Monday morning, we started just saying, okay, well, we're going to build back. So if my first patient was at 8:45, I'm going to take an 8:30 and 8:15 and 8, until that got filled up. Until I said, that's too early. I'm not coming in any earlier than that. And then once that happened, so we would usually schedule them back for that visit. The nice part is that what we found is that it is so efficient in our practice that for some patients, I'll just say, look, we've had this conversation, we've done this evaluation, and I'll say, look, if you want it done today, it looks like we have an opening, because I know it's so quick. We'll wiggle them back into the schedule. But usually we schedule you back on a separate day. But if Monday mornings aren't working for you, we can do it right now if you decide you want to do it that way. The reason that I do that is, one, is that some patients just want to take care of it right away, just like Dr. Nelson said. But two, I don't want, like Dr. Epstein said, I don't want to make patients feel like they have to make the decision right now while they're in the office. They might want to do some additional research. They might want to consider the things that we've got or that we've talked about, and then we can, and then they can feel good about it. But I would say that more often than not now, well, I would say more often than I would expect, and more often than some other treatments that we offer, patients do incorporate that on that same day, and it really doesn't disrupt my schedule. My scribe or my other techs can go get things set up, and I can walk in once it's ready to go, and it takes me less than 5 minutes to actually complete the procedure. So it doesn't really disrupt my patient flow in my normal day. But I was worried about that at first.
I'm going to add something just quickly, because you kind of, all of you raised some interesting questions. Optometry is not used to doing procedures. That's not like the core for most ODs. And I always believe in learning from excellence. I have some close friends who are amazingly successful cataract surgeons, and the reason why they're amazingly successful is that Medicare reimbursements and things have gotten them to be faster at it and more efficient at it, and obviously they have to do it in an ambulatory surgery center. So we started right from the beginning putting it on a specific time and day. We've since morphed to occasionally meeting patient needs. Usually my associate will grab him and say, we have someone who needs that. But, I kind of look at it as a procedure-based, operation, if you will. So, I schedule literally an entire Friday of IPLs, one after the other. We can do, sometimes we'll do 30, 40 a week, including Wednesdays, which is my associate's day. So as you get busier with this, it becomes important to kind of look at it the way the ophthalmologists look at it. It's a procedure, and you may want to take a specific day and a specific time. But that's just a thought that I thought might be worth throwing out there.
Yeah, I also would like to add that when I started practicing, I left a very big practice, 3,000 square feet, multiple. But when I opened it, because I wanted to be very small, I didn't want it to be very small. I wanted private. My office actually very, very small. It's under 300 square feet. So when I started bringing all this technology into my office, I was like, how am I going to make it work? So if there are doctors who are here listening and they think, oh my goodness, I really want to bring this technology to my office, but my office is small, stop you, because you just certainly can be creative. For example, I do my dry consultation on my regular clinic days, but I do schedule dry eye IPL treatments on just one day. What I'm doing is just the whole day I'm doing IPL, so that way I don't have to wheel the machine in and out. I don't have staff. I only have my front desk, and there's me, and I have a virtual assistant. So the point of this I'm sharing is don't let it stop you if your office is small, you don't have help. There are many ways to be creative to make it work, because I've done it. It is possible.
I don't think anyone can object to having this based on footprint size. If you've got a 300 square foot office and you've incorporated that into your office, yeah.
It's impressive.
It is. All right. So when we bring in a new technology into our practice, I think one huge hurdle into offering this technology to a patient is the doctor really has to believe that technology is working and is beneficial to the practice. So can you talk a little bit about some of your clinical responses and outcomes that you've seen from some of the patients that you've treated? And why don't we start with Dr. Nelson on this?
Well, I had a patient that was 32 that came in a year or so ago, and she had tear labs of 380. And they went down 50 points after the fifth treatment. 50 points on a tear lab, I didn't think that was even possible. But she was much better. We got the outcome that she wanted. And I think that this is very, very similar for most patients. It's usually 20 to 30 point drop on tear lab after the fourth treatment. And it's really astounding how well this technology works.
Amazing. Dr. Wolfe.
Yeah, so in our practice, what we generally do when I'm looking at an ocular surface evaluation is we'll look at symptom score. I like speed. I look at corneal staining and conjunctival staining with both lissamine green and fluorescein. We do an tear osmolarity. We do a tear MMP measurement, and then we look at the eyelids. We look at structure and function of the lids. I actually still look at firm expression, kind of forced expression. I also look at the eyelid expressibility. So there's a little tool that probably many people have seen to see how many glands are working every time you blink. I like that number. And And yeah, I think the first thing that I can comment on right away is that almost every single patient, if not every single one of them I can think of, when we're doing their second treatment, they've told me that they felt really good after their first treatment. They had a noticeable improvement. And I can't say that there's been very many treatments that I've been able to offer, maybe steroids, topical steroids, that have been that effective that quickly for patients. And so then after that, then we're measuring all of those other indicators. And really exactly what I would expect to see happen based on the FDA trials is that we see a tear film breakup time improve. Just like Dr. Nelson is saying, that's going to usually be reflected as an improvement or reduction in tear film osmolarity. And then we'll see their symptom scores cut generally by half within that after that fourth series of treatments. And that's what I can tell patients is this is what we expect based on the FDA trials. And this is really what we've seen clinically in our practice as well.
Good. Art, do you want to comment here?
Yeah, actually, I am, and or I will, I should say. I am, and I will. I'm going to actually approach it a little differently. Again, it goes back to New York cynicism, which has often kept me out of trouble and saved me. When I first incorporated the technology into the office, my expectations were actually quite limited. I thought it would help. Based on the research and the data, there was a large body of scientific literature that supported IPL and went into some of the mechanisms for how it worked, increasing mitochondrial activity, photobiomodulation, decreasing inflammation, and some of the things that we've talked about. But I didn't necessarily equate that to the type of performance that Chris mentioned. So I remember we were working primarily with patients who had clear-cut rosacea, ocular rosacea specifically, and I still consider telangiectatic vessels, scattered all over the lids, a prognostic sign for success. Anyway, we started working with this small subset, and patients came back with significant improvements. And again, wary and not convinced that this was going to be game-changing, I began to offer it kind of as a Hail Mary. And, our practice is literally filled with train wrecks. So I figured, like many people do, we often take new technology and throw it at the most difficult patients. And I was actually stunned at the improvements that I began to see. We had one patient who had horrible scarring acne, these deep pock marks. She was probably about in her late 40s, and came back for the third treatment, and the pock marks were literally erased, and her eyes were 1,000 times better. And we had story after story after story until this became mainstream for us. And I was so positively motivated that I think the patients could sense the electricity when I talked about it, because ultimately we want to make patients better, we want to improve their lives, and this is such a direct way of doing that.
Good points. How about you, Ina?
Yeah, so for me, it's very important to have a patient feedback. We know we have science, we know it works, we know it works. When the patient comes back, and after the first or second or third treatment or even fourth treatment, it is very important for me to hear what they say. And what I'm looking for is, are you able to be on the computer for longer? Are you able to do your work? And that's usually yes. Are you able to wear your contact lenses now? And that's usually yes. So these are the things that I want to hear back. And so far it has been it was really great, because this technology is able to treat the patient, and it is just drastically changing and improving their quality of life. I have a lot of patients that have been on, Lumify, on redness whitening drops, just because they're on the computer, they're in the office, and this, that's their life. And if we can use this technology and improve their comfort, their quality of work, their appearance, their aesthetics, once you do this to a patient, patients talk, and then they share these experiences with their friends, and really it's patients happy patient will tell everyone else, and that's how you start to grow this, community of dry eye and treatments.
Does anyone have any sort of anecdotal cases where the patient's life was truly transformed with this technology?
I have one that literally I think about all the time. This was a early 40s female who was a cancer survivor, and she had been treated with apparently rather powerful chemo. Came in, literally could barely keep her eyes open, was absolutely miserable. And this was a very successful, incredibly wonderful person whose life was literally crushed after going through all that. She had virtually no meibomian gland tissue left. I mean, just little nubbins. Lipid layer thickness was 20 nanometers. It was like almost nil. Was remarkably stable, but that's a whole other story because there's compensation that occurs, and sometimes that measure is not reliable. So all the findings were pretty dire. I worked with her using more conventional approaches, my foundational approach, some medications, and then finally, I got to the point where I offered IPL as a Hail Mary to her. Really not only transformed her life, we perform IPL on her every month. And one of the things that I think is an important take home is one size doesn't necessarily fit all. I know we have a tendency to think we're going to do it every 3 weeks or every 4 weeks for 4 sessions. Some patients need more. Some patients would probably get away with less. Some patients need maintenance. There's a small percentage of our train wreck patients who are treated literally monthly, and it allows me to turn her glands on. What's left of her glands now are functional. Her lipid layer thickness has gone up tremendously, and she has her life back. I see her once a month, and I'm reminded of that. And it's the most wonderful experience to have been able to change someone's life like that. And again, I go back to what I said. IPL gives you the power to change people's lives in literally in your hand.
I had a 45-year-old rosacea patient, investment banker kind of guy. And after I treated him the first, maybe 2 or 3 times, he brought a bottle of wine. He said, "Thanks for knowing what to do with me. I mean, man, this has been awesome." And I got him off to an IPL center so they could do the rest of his face. And he's just a changed man.
That's great. Ina, Chris, do you guys have any cases?
Yeah, sure. I can share one that I am treating. She is a cancer patient undergoing chemotherapy and radiation, severe dry eye, severe meibomian gland loss, and what her problem at this point is that her eyes are so dry that it wakes her up at night every 2 hours, and she needs to reapply either it's ointment or some moisture drops. And I've been using the IPL every month on her. And she's just, if I get, sometimes she would just message me because, we're best friends at this point. I do see her a lot. And she said, "I only woke up one time this night because, I think this IPL is really helping." So, if I can have her at least sleep through the night or only wake her up, if she wakes up only once at night, that's a win.
Absolutely.
Yeah, I think there's a patient that comes to mind, and I often think that we do a really good job in our practice giving patients options for treatments, and also letting them know that, look, if this widget is too expensive or going to fit your lifestyle, that we can find something else that will work for you. And one patient that kind of fell through the cracks was that she was on a prescription medication that had worked really well to control her inflammation for years. And then I see back in the chart that she had, her insurance stopped covering it. They prior authed it, denied. We tried a different medication, prior auth it, denied, and she just couldn't afford or didn't perceive that she was going to be able to use it. So I kind of lost her to follow up a couple of years. She had tried to find other people to go to, and then I recently saw her back a few months ago, and and we had this as an option now, and it met her where she was at, and just even after one treatment of not being on an anti-inflammatory for the last couple of years, I pulsed her on a steroid drop. We treated that. We treated her with IPL, and on her very next treatment. So we did it 3 weeks later. Her very next treatment, she was just thought it was just amazing. She had been on a steroid for a couple of weeks, but that whole 3-week period was just totally comfortable for her. And we did the next one, and then she was on any other topical medications thereafter, and same thing. She was. I saw her back a couple of weeks ago, and she just that whole last 3 weeks has been wonderful. So I think it's just really powerful to be able to help patients when we go through other step approaches, and those can't meet their budgets or their preferences, and this really allows us to do that.
These are all great points. We only have a few minutes left here, but I do want to touch a little bit on the financial aspect that this has had to your practice. So can anyone speak on the more sort of financial impact that adding this sort of cash-based treatment to your practice has had?
All right,
yeah, I would say that just in general, when we think about, if you've heard me talk, I've had the pleasure of speaking all across the country about the idea of incorporating new treatments for our patients and really looking at not just ocular surface, but any disease state as a place that we can help our patients primarily, and secondarily help grow our practices. And so this is just another one of those pieces where if we're looking at treating the ocular surface, it's I can show you based on Medicare national averages, it's every bit as profitable as selling a nice pair of glasses and a routine examination. And so it's been a piece of our practice that allows us to meet our patients where they need to be met and take care of the needs they have, as opposed to sending them off to someplace else that can't take care of all of the spectrum of primary care that we do.
So I'll add a bit, because I have an interesting situation. The overarching practice is Phoenix Eye Care, and Phoenix Eye Care has a practice within a practice, which is the Dry Eye Center of Arizona. My wife, works in the primary care side. She does primarily medical eye care. We do, some more traditional optometric, things as well. My young associate kind of goes back and forth. He's primarily in the primary care section. But if we look at amount of income generated on my side and the amount of income generated on the primary care side and the number of patients seen, actually considering that I see fewer patients in a given day, I can generate as much, if not more. Not every day. Sometimes my wife makes me look rather silly, but that's because she's smarter than I am. But at any rate, I think people underestimate how much income you can generate from medical eye care and dry eye, in particular. When we added OptiLight light-based technology to our office, it literally just exploded the practice, and the income generated followed. Our office is literally filled with high-tech stuff. We have a much bigger office than Ines, but it's literally filled, bulging with technology. I've never made a bad investment in technology. It's always paid itself back, not only in dollars and cents, but probably more importantly in patient satisfaction and patient benefit.
I'm happy to share too, since I did share that my practice is very small. So for someone who sees patients, and this is just to put it in perspective, so I see about 15 patients a day, 3 days a week. With adding IPL to my practice, I paid it off in about 6 months. So it's really has changed a lot of things in the practice, and it's definitely has been really financially beneficial for the practice.
Thank you all for sharing all of these points. This has been a phenomenal discussion. Before we wrap, I do want to just ask each of you just to say a little something on something to your colleagues to help them incorporate this technology, anything that you have to offer our colleagues.
I'm happy to start. So we know based on studies that dry eye is a multifactorial disease. And that's why we need a multifactorial treatment, which light-based therapy offers. And I tell my patients, I train my front desk to, really think that way when they talk to, when patients call for a consultation, to schedule a consultation, that, we're able to offer now a multifactorial treatments.
Let's go to our.
Actually, develop a sense of intellectual curiosity. It will lead you in, I think, really productive places. Always ask why. Always have expectations for everything you do, and always focus on the patient. I hate to say this because it sounds trite, but treat patients like you'd want to be treated yourself, from literally your front desk staff to when they're sitting in your chair, and you'll have a satisfying professional life.
That's great. Dr. Wolfe.
I just think that when we think about the continuum of care for all of these patients, I think approaching patients with the expectation, as Art said, that you're going to find something, as opposed to just thinking that those patients are just kind of a run-of-the-mill patient. When you do that and you don't find anything, you're pleasantly surprised. But more often than not, especially if you look at prevalence data, you're probably going to find something that's worthwhile managing. And this is going to be more than likely, meibomian gland dysfunction, ocular surface disease is going to be more than likely on the top of those lists of things that you'll find. And if we don't take care of these things from a primary eye care standpoint, ophthalmology doesn't want to, and they're not going to have the time right now, and even in the next 10 years, they're definitely not going to have the time. So it's going to get missed, or some other profession is going to come in to fill the niche, and we can't let that happen. And you're paying to afford to let you have that happen either. So continue to push forward as a profession and integrate new technologies that can really help our patients.
Dr. Nelson.
Well, what I've always found, if you do the right thing for the patient, you do the right thing for the practice. And this device, well, the company doesn't sometimes like me saying this, but it spits out $100 bills. It's just and it works 4 different ways. It works on heat. It works on Demodex reduction. Dr. Jaclyn on yesterday talked about the prevalence of Demodex being 70% in people 35 and over, and it kills them on contact. It is a significant problem. Look for it. It gets rid of telangiectasias, and it's red light therapy. It's intense red light therapy. And it's 5 minutes in taking care of people 4 times over 12 weeks, as opposed to something like low-level light therapy, which is 30 minutes 3 times a week for 12 weeks. It's a time suck. So anyway, it's quick, it's good for patients, and it's great for the practice. So that's all I got to say.
Thank you all so much. As I said, I have yet to talk to a doctor who has implemented IPL in their practice and hasn't found it to be extremely rewarding. So thank you so much for taking the time today to share your experiences with us.